One of the major immune system problems that affects the kidney significantly is vasculitis. And there are several forms of vasculitis that affect the kidneys, but I'm particularly interested in a form called ANCA-associated vasculitis, which many of you will have heard of. Some people call it GPA, MPA, or EGPA, but these conditions commonly and critically affect the kidneys. So I guess I've come to vasculitis from an organ, a kidney-based approach, but over the years I've got very interested in really what's happening in vasculitis and why is it such a tricky disease to understand and to treat. What happens in an autoimmune disease is, unfortunately, our body, which has been trained to recognize our own proteins and our own molecules as harmless and something just to go along with and be tolerated, there's a great deal of confusion that happens for a variety of reasons. And in ANCA-associated vasculitis, what happens then, it sets in train some events that not only allow us to measure these antibodies to proteins that are found in immune fighters called neutrophils. These proteins are called proteinase 3 and myeloperoxidase. But also what happens then is these neutrophils get activated, and this is sort of the initiation of the autoimmune process. And then you get this nasty inflammation of small blood vessels, and particularly vulnerable vessels like lungs, kidneys, and in the nose. And this results in damage, inflammation, and then damage. And many of our treatments have justifiably and reasonably and very successfully been focused on inflammation and preventing inflammation at the sites of injury, like the kidneys, for example. And although we are interested in that and have done a fair bit of work on that, I guess we've wound it back a bit to try and look at the basic and fundamental problems here. That is, why do we lose tolerance to these proteins and what happens? With a view that if we understand that, then we can perhaps do something about it. So I guess our vision is that eventually we'll be able to use fairly targeted things to turn off inflammation, to quieten down neutrophils, dampen down these antibodies, but eventually either at the same time or after remission has been achieved, try and reset the immune system so it no longer recognizes these neutrophil proteins as foreign and dangerous. Now, we might be doing that already sometimes with our current treatments, but we just don't know. We can't measure it, and that's an additional problem. We can't really predict what's going to happen, and those of you who are patients will probably know when you talk to your doctors, it's very hard to work out from the doctor, because they don't know, what's going to happen to you. Will this come back, or will it not come back? So we figure if we understand what really happens, and particularly identify the parts of the MPO, myeloperoxidase, and proteinase 3 molecules that cause this problem or that are targeted in this problem, we can perhaps measure the way our body's responding to them and eventually use one of a suite of emerging techniques to reset the immune system that allows us to, I guess, call someone cured. So if we understand what's happening, we can then get better testing to work out what's going on, and that leads on at the same time or at different times to potential therapies for this condition. Current treatments are good. They've saved lives indisputably. But as you will know, if you're a patient having to take these medications, they also target what I call the good parts of the immune system, those to protect you, for example, from infection. So what we'd like to do is hone in on the very cells and antibodies, for example, that are causing the condition, so we can do this in a much more targeted and focused way. Recently, we've made great strides in the treatment of vasculitis by taking people with vasculitis and taking ANCA-associated vasculitis and taking, unashamedly, a bit of a one-size-fits-all approach. In other words, we've treated people in recent trials, like the PIXIVAS trial, in certain ways, and that's been great. What we've been able to do, for example, is pretty much halve the amount of glucocorticoids, prednisolone, prednisone, corticosteroids, call it what you will. Some people even call it Satan's Tic Tacs. So essentially, we've been able to halve the dose of that we're giving to people initially, and that's been a great success. But along the way in the last 10 years, there's an increasing recognition that people are different. For instance, there are significant differences even within ANCA-associated vasculitis between those who react to myeloperoxidase and have what we call MPO ANCA, and those who react to proteinase 3 and have what we call PR3 ANCA. So this leads to the question of precision or personalized medicine. And my understanding, although personalized medicine would be great, the current term that people are using is precision medicine. Personalized medicine is a huge leap. Of course, we should treat everyone like a person, but we need to group people, stratify and group people into categories of not only whether they react to proteinase 3 or MPO, but also what their likelihood is of recurring of disease. What's the consequences of things reoccurring? Are there subtle differences within the groups of people who react to MPO and PR3? And those are the kinds of things we need to learn to develop precision medicine. So that's the kind of thing we need to be able to do to be able to more precisely treat people. So I guess, yes, what I am working towards, what we are working towards, is a form of precision medicine, and that rather than say, you've got vasculitis, we can now say, you've got ANCA-associated vasculitis. In fact, you've got MPA or GPA. We can now say, you've got GPA, for example, and you're reacting to PR3. And hopefully in the future, we can then say, and this is your likelihood. You're a high likelihood of recurrer. And we can maybe do a test and say, and it's highly likely in 3 months' time you will recur if we don't treat you. And therefore we can tailor the treatment. Not only these new targeted treatments we're perhaps looking at, but also more conventional treatments that tend to work pretty well. And I guess our improvements in vasculitis treatment in the past 10 or 15 years have really come from, as well as rituximab, has really come from using conventional treatments better and in a more informed manner. And I guess in a way that's a form of precision medicine itself, and something that I think the research community in general is very aware of in vasculitis and is moving towards. I haven't talked about one really important thing, which is doctors tend to measure tests and say, oh, you're great, but often the patient can feel really bad still, particularly tiredness is something we really don't recognize as much as we should, and I have over the last few years recognized that as a major problem, and things are coming out too. So I guess the other thing we've got to do to get to precision medicine is listen hard to what the patients have to say, and develop and use more sophisticated tools that not only measure blood tests, but measure how the patients are feeling and their quality of life. So I guess we need to build that into a precision medicine type of approach as well. The Vasculitis Foundation has been very helpful to me and my research over the years in Australia. And most recently, they've been funding a colleague of mine as a young investigator, Dr. Dragana Odabasic. And she has been using some of the discoveries that we've made to test one of these platforms that may help, treatment platforms that may help restore tolerance, immune tolerance, and reset the immune system. And so this funding's really been vital to help with our broad spectrum of research in this area so that we can find which the right platform is to start using in patients in initial phase 1 trials. And to do that, you've got to do a lot of preclinical work first. And this is the kind of work she's been doing, and it's been extremely helpful. And lastly, the Vasculitis Foundation has kind of acted as a benign, helpful big cousin in helping us in Australia set up our own vasculitis society. We really did something in Australia and New Zealand to work together across disciplines to help research, education, and patients with vasculitis. So we decided after much thought to set something up new from scratch. So we set up the rather obviously called ANZVASC, the Australian New Zealand Vasculitis Society. And after much debate, we made it a professional organisation. But we also decided that we needed to be, in this day and age, and this was the right thing to do, very outwardly patient-facing. So we're also, we have patients as members, and we have patients on our board and on our committees as well. So we exist as a charity, and we're young, and we're aiming to make a difference in education and training, research, and we're starting up what we think is really important for clinical care and quality of care in Australia, a vasculitis registry. And the Vasculitis Foundation, and Joyce Kuhlman in particular, has been very helpful in that. She shared ideas, some resources that the VF have developed, and been really quite supportive in helping us set up something new here down in the Antipodes that we hope in now and in the future will help our patients. We really, it's something that the Vasculitis Foundation has been incredibly helpful for us over the years. And if you happen to look at this in Australia, New Zealand, go online, and we'd like you to join us.